So why did we choose this topic? I'm really just excited for you to listen to Dr. Banerjee because he's come up with a really interactive, fun slide deck about dexamethasone and how it could be the hero or the villain of our story. I feel like I meet with so many patients that are frustrated with the side effects of Dex or misunderstanding why Dex is used in almost every treatment. I think some people have negative reactions to Dex. Some people that I've met love their Dex days. They take their friends on shopping sprees. Most care partners hate Dex days because then they have to interact with their loved one who is behaving not as they normally do. I just know there's a lot of misunderstanding and hate out there for dexamethasone. There's people that are not compatible with dexamethasone and have to receive other steroids. So finally, I just wanted to sit down with you guys and have a discussion about Steroids 101. Darn that Dex. Let's learn about how it could be the hero or the villain of the story. And here to present us this awesome presentation is Dr. Banerjee. His clinical interests are multiple myeloma, AL amyloidosis, and CAR T therapy. His research interests are in toxicity management, digital health, and the patient experience. He's an assistant professor in the Division of Medical Oncology at the University of Washington, go Huskies, and an assistant professor at the prestigious Fred Hutchinson Cancer Center. So, with that being said, I'm going to stop sharing and turn the time over to you. Thank you for
Wonderful.
being here, Dr. Banerjee.
Of course, thank you, Audrey. It's a pleasure to be here. Let me share my slides first. And then we will get started. Can you see my slides correctly?
Not in presentation, or yes, now we can. It just took a moment.
Perfect, absolutely so. Okay, so I'll go ahead and get started. Thank you all for taking the time in the afternoon or evening, depending on your time zone, to check in. Again, my name is Dr. Banerjee from up here, Pacific Northwest in Seattle, and I'll be speaking about dexamethasone, the hero or the villain of myeloma therapy. Thanks again to Audrey and to the myeloma crowd or HealthTree community for inviting me to speak here. Here are my disclosures and acknowledgements. And then I'll note for those of you listening to this or looking at the slides later, anything where I put PMID at the bottom of each slide, that's a study reference, and you can actually search for that PMID PubMed identification in pubmed.gov to look for the actual manuscript or the publication that I'm discussing. So the reason I chose this quote was actually, some of you may have seen this The Dark Knight, one of many, many, many Batman movies, almost as many Batman movies as there are types of therapy in myeloma. This is from the district attorney here who says, you either die a hero or you live long enough to see yourself become the villain. And that kind of journey matches dexamethasone in some ways in myeloma, and my goal is to kind of go through that and then obviously spend some time to talk about practical tips for all of you when you're on dexamethasone or not on dexamethasone in terms of what to expect. So we'll spend about the next half an hour speaking about these kind of things, including kind of the origin story, where steroids, dexamethasone came from in myeloma, then steroids as the hero, steroids as a villain that many of you are quite familiar with, and then again, practical tips, and we'll spend obviously the bulk of our time answering questions about this thereafter. So let's get started, kind of continuing my Batman metaphor here, the origin story. So first, what are steroids? So corticosteroids are hormones that are made by our adrenal glands just above our kidneys. They have quote unquote neuroendocrine effects. So hormones act from afar and kind of change our entire body at once. And all of you may remember this term fight or flight from high school. That's what steroids are known for, the stress response, handling not necessarily emotional stress, but physiologic stress when your body's revved up. Practically, they do manage our immune response to inflammation. And then glucocorticoids, which are a subtype of steroids, manage electrolytes, so sugar levels in particular. Alluding to that, so two types of corticosteroids or two types of actions by corticosteroids. Glucocorticoids, like what we'll be talking about, focus primarily on the immune system and your blood sugar levels. There also are mineralocorticoids that focus on your blood pressure and potassium levels. Importantly, some of you know this, most of you have heard this, these are not the same as anabolic steroids. Those are kind of the injections of testosterone supplements to help boost muscle mass. If anything, these are kind of the reverse of that in some ways. In terms of glucocorticoids, again, they are a subtype of corticosteroids, so a type of steroids that focus primarily on blood sugar, hence the word gluco or glucose. So kind of the opposite of insulin in terms of how they work on the body. They generally tend to raise your blood sugar. Cortisol is the all-natural glucocorticoid hormone in our body. Some of you have heard of this idea of cortisol levels corresponding to surging of stress levels or sugar or anything. There are 4 synthetic glucocorticoids available in the US. Hydrocortisone is the same as cortisol, prednisone, methylprednisolone or solumedrol, and Dex, the beloved Dex that we'll be speaking about today. Importantly, of course, these can be given in all sorts of ways. Many of you have seen, for example, hydrocortisone cream over-the-counter ointment for kind of topical inflammation to kind of get rid of rashes. Same principle, obviously, but that's generally only for the skin. Systemic steroids are either oral or IV and obviously act on the entire body at once. So then zooming into dexamethasone in particular, it is the strongest glucocorticoid that we have. So I showed you on the right here, not that I am a chemist, but you can see just a couple changes here. There's a little fluorine here and one of these rings changed and whatever. And all of a sudden, dexamethasone ends up being 20 times stronger than natural cortisone molecule for molecule. Is 100% bioavailable, which that's a fancy way of saying that the dosing orally is the same as the dosing IV, because all the dexamethasone that anyone takes as a pill gets into their bloodstream 100%. Not all drugs are this way, so we can never can assume that in medicine, but here, for example, some of you, whether you take 20 milligrams orally or IV in clinic, exact same thing. And thankfully, dexamethasone is relatively affordable. It's been around for a very long time. It's a quote unquote essential medication. And so, for example, on GoodRx, it is less than $5 for a 40 milligram for a 1 week supply of Dex as 4 milligram tabs. The steroids have been around for a while. Beth Feynman at Cleveland Clinic actually showed me this slide this is a study from the 1990s looking at prednisone, for example, being used as maintenance, which you don't do anymore, improving survival in patients with myeloma. But really, Dex has been kind of the star of our show for at least the last 30 years, if not longer. So this is an example of a study of high-dose Dex from back in the 80s. So this was here, you can see that these patients got dexamethasone 40 milligrams every morning for 4 days. So they would take it for 4 days, stop for 4 days, take it for 4 days, stop for 4 days, and so forth, as part of a combination drug that included vincristine. It's not Velcade, a drug we don't use anymore for myeloma, and adriamycin or doxorubicin, which we also typically don't use anymore for myeloma. There were some studies of Dex literally just by itself. So the same principle, Dex here, this was mg per meter squared, but practically about 40 milligrams daily for 4 days and off for 4 days, daily for 4 days and off for 4 days in these patients. And some patients had responses even just with that all by itself. Again, this is also a study from 1992, so very long time ago by modern standards. Some of you may be asking, because all of us, we say that our patients are on high dose Dex, which is correct. I would call Dex 40 milligrams weekly high dose in my mind. So then you might be saying, well, I thought that was high dose. What is this? So that's kind of super, super high dose. And really, until the 2000s, we weren't really sure how best to approach dexamethasone in myeloma. So you can see there actually was a study here. This was an ECOG study. So this was a cooperative group of not funded by a pharmaceutical company, kind of all the researchers and physicians coming together to study this, looking at what was then considered to be high dose Dex. So again, 4 days of straight 40 milligrams and then 4 days off and then 4 days on and 4 days off and 4 days on and so forth, versus what many of you may be more familiar with, which is dexamethasone several pills once per week, for example. This was a randomized study, so patients were randomly assigned to both of them in the newly diagnosed setting in combination with lenalidomide, which is Revlimid. At this time, we tended to use doublets and not triplets or quadruplets for myeloma, so this was a doublet with lenalidomide and either high-dose Dex, meaning 4 days on, 4 days off, or 1 week at a time. And so at first glance, the high-dose Dex had an overall response rate that was better. Overall response rates mean that the myeloma blood numbers come down at least 50% or more, and that looked better. So I have no doubt that the higher the dose of steroids, the more the steroids kill myeloma cells. However, when they actually stopped the study early, because they looked at the data, they found that patients who were getting high-dose Dex were actually passing away at higher rates, unfortunately. You can see here that at the 4-month mark, 5% of patients in the high-dose Dex group had died versus only 1 patient in the low-dose Dex group. And you can see here, you'll see a couple of Kaplan-Meier curves that are shown here, and we can talk about these. Are confusing, but basically on the y-axis here, this is what percent of patients are alive. On the x-axis here, you can see this is number of months, and you can see, for example, by 1 year, maybe only about 90, maybe 85% of the patients in the high-dose Dex group are alive versus closer to 98% in the low-dose group. And that graph kind of looks at that in more detail. And basically, long story short, the rates of progression, which is our word for relapse, but a myeloma coming back, were similar between them. But the red line is higher than the blue line, which means that patients were dying more for non-myeloma reasons in the high dose group. The main causes of death here really were then blood clots and infections. There was no difference in rates of relapse with that in mind. And so the lessons that we kind of learned from a study like this are really threefold. So one is that we very, very quickly stopped using dex, this kind of approach of taking 40 milligrams every day for 4 days and stopping, then starting, then stopping, for example, and moved to a once weekly paradigm. We learned that blood clots are very possible and possibly lethal in patients who are getting those kind of ultra high dose steroids. They're not an issue with low dose steroids by themselves. Revlimid with lenalidomide, they are. Some of you may be, most of you probably are on blood thinners, for example, but that's not because of the steroids anymore, the doses that we use. And the biggest plug that I wanted to make here, and this is kind of from the International Myeloma Foundation, a tribute that they gave to Michael Katz, who I never had the privilege of meeting, but he was a patient who was both a patient and a patient advocate. So he served on the ECOG, on this cooperative group committee, and he really, really pushed for the study to happen, being like, hey, we just made up our dex doses. Let's try a lower dose and see what happens. And really it was thanks to him pushing for this trial that this trial happened. And obviously that our entire practice for all of our patients a decade later has been changed substantially. With that, I'll stop and move on to kind of in the last decade now, fast forwarding to the year 2022, what do steroids bring to the table? What do they really take away from the table in terms of their side effects as the villain? And then how do we manage things? And then again, I'll spend the bulk of our time answering questions from all of you about, how I approach steroids and how I would approach them in individual cases. So this is not meant to be a biochemistry talk, so I'm not going to go into all the details of this. There have been several studies that show that dexamethasone does make other anti-myeloma drugs work better. The word that we use is synergy. Synergy basically means that 1 + 1 = 3, where the combination of drugs works better than you would expect from either drug working by itself. The idea being is that steroids work on many different pathways within myeloma cells and might make them actually promote different proteins intracellularly that makes them more susceptible to other drugs. So here are just some examples here with selinexor, which is a new drug that blocks export of certain proteins. Bortezomib, which is Velcade that many of you are quite familiar with. This is iberdomide, which is a new CELMA drug, not yet FDA approved, but probably will be a replacement to lenalidomide and pomalidomide someday. And here's one with pomalidomide. A lot of these are preclinical studies, but have shown this principle that in a petri dish or in a cell model, for example, if you just put steroids over here and then put some other drug over here and then put steroids and the other drug together over here, the combination effect is the most salutary. It has the most beneficial effect in terms of killing myeloma cells. There have been clinical studies that have shown this as well. The caveat is in that these two studies that I'm showing here, for example, we don't generally use doublets by themselves in most cases, but this was a study of pomalidomide or Pomalyst, which is a newer version of IMID, of Revlimid or lenalidomide. I got another Kaplan-Meier curve here, but they looked at POM with dex versus POM alone. And you can see here that basically the dark line looks better. This is progression-free survival. This is how long patients remain in remission without the myeloma coming back, requiring another therapy, or unfortunately passing away. And you can see, for example, here that at 10 months, for example, here, not great numbers, but numbers all the same, about maybe 30% of the patients in the POM low dex arm getting POM with dex were still in remission versus closer to only 20% in the patients who were only getting Pomalyst by itself. This is a study here in the relapse setting more recently that was published last year with isatuximab, which is Sarclisa, a monoclonal antibody similar to Darzalex or Dara that many of you may be more familiar with. This one was a little bit more impressive here, where the median PFS, so meaning how long the average patient, 50% of the patients were able to make it without the myeloma coming back, was, if you look at the 50% mark here, was 10 months in the arm that was getting isatuximab with dexamethasone versus only 5 months in the patients who were getting ISA by itself without the dexamethasone. So there is clearly some benefit, even in the modern era, because this is the drug, these are drugs that we do use all the time today, of adding dexamethasone in terms of tackling the myeloma. Other things that steroids bring to the table. So Dex is a very powerful anti-inflammatory drug, as I talked about. That's kind of the principal sine qua non of why we have dexamethasone in general as a drug. And so for a lot of our medications that are antibodies, or what we call monoclonal antibodies, we do require dexamethasone as a pre-medication before them. Just to talk through what that practically means, unlike a classical drug like Velcade or lenalidomide, even for example, a MAB or a monoclonal antibody is actually generally, in most cases, actually mouse derived. So it's actually a mouse antibody where it's basically we figured out how to make a mouse antibody that attacks human myeloma cells, and then we started to convert or synthesize that particular antibody in a lab. So this is not, mice are not dying directly to give these drugs, for example, but it was derived initially from a mouse protein. And so you're basically either infusing or injecting a mouse protein directly into your bodies, which sounds terrifying, and your immune system appropriately gets kind of really confused and starts to often attack the actual antibody itself to begin with. And so we often have to give steroids to help calm down that hyperinflammatory response to begin with. So here are some examples here where this is for Darzalex or Dara. We recommend Dex 20 milligrams beforehand, especially for the first couple of doses, then we can drop it. This is for Sarclisa or isatuximab, the same principle, 40 milligrams or 20 for older patients. This is for elotuzumab or Implicity, which is another type of monoclonal antibody. You can see they recommend here a combination of basically 36 milligrams of dexamethasone orally and IV, leading into every infusion from the beginning to help avoid these infusion reactions. Dex can help with nausea and with pain. Audrey alluded to this, and I have had patients who actually feel their Dex days are actually better for them. Their pain is better controlled on those days, especially in the beginning of therapy with myeloma. It doesn't happen for everybody, but for many times when patients are having uncontrollable pain, I will sometimes use Dex 40 milligrams daily for 4 days, just like the super, super high doses of steroids I'd mentioned, 20 years ago. Importantly, though, I don't keep doing it again and again. We give it, and then we try to taper it. We try to do something else to kind of get control of the pain more definitively, like radiation therapy or starting new drugs for the myeloma, and go down on the steroids. But steroids do work, both in terms of pain flare, as described here, especially for bony pain, but also for, this is an example for all patients with cancer, but for chemotherapy, we often do use dexamethasone. So for example, for some of you in the audience may have gotten VD-PACE or DSAP or CVAD or even a stem cell transplant, that we do sometimes use steroids with those regimens with the high doses of chemo purely as a way to control nausea. But now that I've talked up steroids and how quote unquote awesome they are in some ways, we'll talk to kind of bad blood here, steroids as the villain in terms of the far more common side effects that people experience that are often negative with these drugs and not positive. So actually, HealthTree has done some features on this before. So Jenny Ahlstrom, who I think is either the founder or the CEO of Myeloma Crowd HealthTree, if not both, she's wonderful. She's been a tremendous patient advocate, and with this site and just in general. So she has several articles on this website, some of you may have seen, specifically about dexamethasone. And you can see the very typical story they hear from patients, right? She all of a sudden, after being diagnosed, she was lying in bed till 2 a.m., neat freak, going to the laundry all the time, indignant, mad at my kids. My kids are all of a sudden really loud, crying, enraged, all of this. And her husband was like, what is going on? And we realized it's not the myeloma, it's not anxiety, that's the steroids for sure. She actually even wrote a song about it that I encourage you to check out if you'd like. So this is, again, not new. It's very common for people to have side effects from steroids. To talk through what to expect, what many of you are experiencing. So some of this is physiologic. So it's this kind of quote unquote fight or flight response that, again, I mentioned that all steroids, all corticosteroids, all cortisol mimics are known for, is a stress response. It's kind of like running from a tiger, fighting a tiger kind of response. So jitteriness, anxiety, insomnia. Most patients say that they are able to stay asleep, but it's falling asleep that's a difficult part. Irritability, and then what Audrey alluded to, that the caregiver notices that, oh, my partner is a monster on steroid days. Some patients, some caregivers tell me that, oh, my partner, I love when they're on steroids because all of a sudden they want to clean the house and cook food, and I love that. But most patients kind of a negative thing. That's a stress response. In terms of blood sugars and electrolytes, a lot of our patients, this is just how steroids work. They do increase their appetite. They do cause weight gain just from appetite alone. Sometimes can cause blood sugars to go up as well for patients who are diabetic. For most patients, steroids will cause some degree of leg swelling. The medical term for that is edema. So you may notice that your legs are more swollen. Maybe sometimes it's just very subtle at nighttime or in the morning you notice it. Sometimes patients say that the shoes are a little tighter to fit than they were before. That's all leg swelling from the steroids most typically. Steroids do suppress stomach acid, so some patients might notice that they get heartburn or just kind of burning in their stomach afterwards, and that can happen as an upset stomach purely from the steroids itself. And then that's on the days that you're on the steroids. Other patients notice that they fear this roller coaster of hormones, so they have what's called a letdown effect or a withdrawal effect. So the day after the steroids, for example, they feel very fatigued, they're in bed all day, for example, and that's all equally problematic. That's kind of acute issues. Chronic issues, so kind of for patients who are on steroids for a while, including many of you who are listening to this. So steroids can absolutely impair bone health. It's complicated how they do this. They both interfere with the ability of your body to metabolize new bone, but also kind of in some ways may encourage your body to break down all old bone from cells that are called osteoclasts. The word for this kind of generalized weakened bones is called osteopenia. Steroids, this is more controversial for weekly steroids. I actually don't think it's that big of a problem for steroids once a week. But for those of you who end up being on steroids more frequently than that, you can be at risk of infections like that old ECOG study showed. So some of you, for example, if you also have another risk factor like uncontrolled diabetes or low blood counts from some other medications, you may also be on yet another anti-infectious medication called Bactrim or Septra. Generic name is sulfamethoxazole trimethoprim. Those that prevent rare infection, something called PJP. This is different from shingles. So most of you probably are on acyclovir. Acyclovir is to prevent shingles from coming back, and that happens with any proteasome inhibitor like bortezomib Velcade or carfilzomib Kyprolis, or from a CD38 drug like daratumumab Darzalex or isatuximab Sarclisa. So all of you will be on acyclovir. Some of you may be on Bactrim or Septra, and that is a side effect of something else as a risk factor plus being on steroids. Steroids chronically do cause skin and muscle issues, so you can notice acne, easy bruising. Some patients will feel like their core muscles and their kind of upper arms and thighs are a little bit weaker than they were before. Generally, that's not as common with once-a-week dex as it is with the high-dose dex of the days of yore, but certainly can happen. It's something to talk to your doctor about if you're experiencing it. And then a lot of our patients may have high blood sugar. So that can manifest in many ways. That can cause blurry vision just from the steroids themselves. That can cause prediabetes or tip people who have prediabetes over the fence into actual diabetes and more. So just to highlight some practical examples and to showcase that there are researchers who are working on this. This is a study that not published yet, but it was done by Dr. Corday's group at MSK, Memorial Sloan Kettering in New York. And they actually gave patients a similar to a Fitbit, like an activity monitor they would wear throughout the day. And basically looked, you can see in this diagram here, orange are the dex days, green are the non-dex days. And on this particular graph, the more sleep someone got, the higher the lines are, the less sleep they got, the less. So you can see for some of these patients, some of them you can actually see on dex days that they absolutely are sleeping less objectively by the sleep monitor. Like this poor gentleman or lady here, I'm actually not sure what the gender was. You can see that this is the lines here, the boxes are the 25th to 75th percentile of how much you're sleeping. And you can see this patient on the days that they're on steroids, they're sleeping less on average than the worst 25% of the non-dex days, for example. This tends to be more pronounced in younger patients than older patients. We don't entirely know why. Thankfully, in the study, when they average things out, the average sleep per night altogether was only 6 minutes per night on average, less altogether over the entire induction study period. So basically, patients, probably do sleep more on the other days to make up for this, but still, this is a problem. Another example, this was data that was very recently presented at IMS, at our International Myeloma Society meeting 2 months ago in Los Angeles by Dr. Popat, who kindly gave me these slides. He's based out of the UK. And basically, if you look at adults aged 60 to 70 in the US population, cataracts, these are some other studies that show that's about maybe 10 to 30% of patients have cataracts in general. About 1 to 4% of patients in general have glaucoma. If you look at this study, this is the DREAM2 study of patients who were getting belantamab mafodotin or Blenrep. This is a drug that can cause ophthalmologic or eye toxicities, and so all of the patients were required to get an ophthalmologist to look at their eyes before starting. And you can see here that in this study, 60% of the patients did have cataracts going into the study, 12% of patients had glaucoma going into the study. And in terms of why all these patients suddenly had all these issues, way more than the US population, Velcade can sometimes cause some of these, but I would say the big risk factors are steroids, and more steroids in terms of eye issues that these patients had. Again, these are patients, these are not newly diagnosed, these are patients who had at least 3 prior lines of therapy for myeloma. So it had myeloma for several years, had been on steroids on and off for years during that time frame. And this is one of the long-term side effects that absolutely we can objectively measure as being a problem. The other side effect for Dex is polypharmacy. That's a very fancy medical word of just saying too many medications that patients are taking. I'm sure all of you will laugh and be like, oh, that's my life right now, living with myeloma. You know, in general, polypharmacy is bad because we've studied polypharmacy in other scenarios and other types of cancer, and it leads to higher out-of-pocket costs, obviously. It's more easy to forget a med if you have so many medications you're juggling around that are sometimes every 12 hours, like acyclovir, or every day or once a week. Some medications can combine similar to synergy, but in a bad way now, and cause side effects in a more pronounced manner, like falls or dizziness. And that's just, you know, for our patients with myeloma, again, we generally, as doctors in general, define polypharmacy as 5 or more meds on someone's list. And just most of you in the audience listening are probably on Revlimid, you're on aspirin because of the Revlimid or a different blood thinner, you're on the Dex once a week, maybe you're on a medication like Ambien or Zolpidem, I'm sorry, the generic name to help with insomnia from the steroids, and you're also on acyclovir, so boom, all of you now by default have polypharmacy. Is not your fault at all, it's the myeloma's fault. And so it's just frustrating. And then, of course, separately from this, that definition doesn't take into account the fact that Dex only comes in 4 milligram tabs at the most. So all of you are also kind of, you know, chugging 5 or 10 pills a day, and we're aware of that. That's a problem. Of note, you know, recently there actually is a 20 milligram formulation of Dex specifically for myeloma. The brand name is Hemati, and one study showed that a 20 milligram tab of Dex was equivalent to taking 5 of the 4 milligram tabs, for example. Unfortunately, why aren't more patients on it? I actually don't have any patients who are on it. I think this is why, because insurance companies is very expensive. And so at GoodRx, at least, the cost for a 1 month supply is $200 for this 20 milligram tab formulation versus $15, for example, for dexamethasone. Oh, plenty of issues there, plenty for us to talk about in the discussion. What I'll do now is pivot to the final part of this discussion, which is some of the practical tips that I recommend for patients who are on steroids. You know, as they're dealing with them in terms of dealing with the side effects, or maybe even talking to their providers about changing the dosing of it or so forth. So with that in mind, just in terms of lowering the dose of steroids, so since that ECOG study was published a decade ago, most studies now use Dex 40 milligrams weekly for most patients, and most studies now have a pivot now where for patients who are age 75 or older, which is a very high cutoff in my mind, they lower the Dex to 20 milligrams weekly. For patients who are on trials, I'm often stuck because my hands are tied by the study trial itself. But for patients who I'm just treating in practice, what I tend to do is I counsel patients that, look, this is one of the drugs that you'll have side effects with. I do start patients, generally speaking, who are under the age of 75 on 40 milligrams, just because that's what was studied. Any issues whatsoever, no questions asked, we can drop it to 20 milligrams. Any issues to 20 milligrams, I can drop it to 12 milligrams. There are some studies that coincidentally use 12 milligrams and it happened to work. There are no randomized studies here. I can't prove that 12 milligrams works as well as 40 milligrams, but probably does. If people are still having issues thereafter with the steroids, I typically then either stop the steroids, or there's some thought, no one has studied in the randomized fashion, that other steroids like methylprednisolone or solumedrol might have lower risks of these. So for example, you know, for our patients who need steroid pre-medication before Darzalex, daratumumab, or isatuximab Sarclisa, and you don't like the steroids, I can sometimes use methylprednisolone instead, for example, solumedrol, and that might theoretically help with some of the jitteriness, but I can't really say for sure. Obviously, talk to your doctor. They put the little caveat here about your case because every case is different. That's the total dose of dex per week. Can the timing of the dex be adjusted? Actually, it's worth considering. So this is a nice publication from the nursing literature about what they sometimes recommend, and I completely agree with this. So instead of doing dex 40 milligrams weekly, if you're noticing you're just having pronounced difficulties with sleeping on the day of the dex, you could break it to 20 milligrams on day 1, 20 milligrams on day 2, and then again the week after, 20 milligrams on day 8, 20 milligrams on day 9. Some of you in the audience may already be on that regimen. Some centers have gone doing that by default, by having 2 days of steroids on, 5 days of steroids off. There's no right answer. It has not been studied in a randomized study, but that might help a little bit in terms of avoiding these peaks and troughs and roller coasters of being on steroids. Importantly, most of you remember this, but I think it's worth to remember or have heard this, but naturally speaking, cortisol levels are highest in the morning, in the early morning at dawn, really. So the closest you can take the steroids to dawn, the better. Obviously, please don't wake up at dawn, depending on where you live, to take steroids. It's not that essential, but the earlier you can take it, the better, in terms of just kind of mimicking what your body is naturally doing and avoiding some of the insomnia and jitteriness thereafter. For those of you who are getting dex in clinic, either as part of your myeloma therapy or as an allergy pre-medication, sometimes we can't change that, especially for clinical trials or for the first couple of doses of treatment. Some centers just require, for safety reasons, that the dexamethasone be given in clinic. But as soon as that's not required, talk to your doctor and say, look, if you trust me, would it be okay if I took the dex at 8 a.m. before driving in, and then by the time that you see me in clinic, it'll be an hour since then at 9, and then I can get the other medications, for example. That might be helpful both to maximize, again, this kind of dawn effect in terms of when steroids are best dosed, and then just making a plug to my own research. I really am interested in kind of home time and kind of avoiding how much time patients have to spend physically trapped in clinic. And you can imagine some of you have experienced this, right, where the nurse or doctor says, all right, you got the steroids in clinic and now you have to wait 60 minutes by definition until we can infuse the drug. And if there's a way to shift that so you can take the steroids at home orally, and by the time that you drive into clinic, get on the elevator, wait in line, get your blood tests, get room, get your vital signs checked, it's been an hour and now you can just go straight and get your therapy, totally worth pursuing. In terms of whether to stop the dex altogether, so with induction therapy, so for patients, induction therapy means kind of the first 4 to 6 months of therapy where we're just trying to get the myeloma into a very good partial response. So 90% reduction in the myeloma numbers, or ideally a complete response into remission entirely. Yes, it is possible. Generally speaking, we try to lower the dose if we can and get away with it. We can't always. There was a study that was published, a randomized study. I love randomized studies in medicine because they're the best way to prove that anything actually works. But unfortunately, it's very difficult to execute them for a variety of reasons we can talk about. This was an Italian study published last year. These were in patients who were somewhat frail. We have a way to kind of quantify frailty or just how physically fit patients are or aren't going into things. So these are older patients who weren't quite as healthy as they were 20 years ago, for example. They used doublet induction, which we don't actually do anymore. We typically use triplet or quadruplets, but they gave one arm of patients randomly Revlimid plus just the dex forever. And then just gave the Revlimid by itself. And then, arm one got Revlimid dex and then just got the Revlimid and they dropped the dex. And the other arm got Revlimid plus dex forever. And basically the two arms performed equally efficaciously, and there were fewer issues of low blood counts in the arm that got the Revlimid plus dex than just the Revlimid by itself. So there was some benefit there, or at least there was non-inferiority, meaning that it was totally fine to drop the steroids in these patients after 9 months. That's still a lot. Induction therapy often only lasts 4 to 6 months, so the jury's kind of still out. For some of you in the audience may have AL amyloidosis, which is a diagnosis where there's a qualitative issue with the M protein in addition to the quantitative issue with the myeloma. For those patients, and if you have amyloid in the audience, I would say strongly drop the steroids as quickly as possible because steroids cause even more issues in patients who are on amyloidosis, who have amyloidosis. For those patients, I would probably drop it as soon as I can. For most other patients, I drop it, meaning drop it entirely from the regimen during induction, only if the patient's having side effects or issues. Then with regard to consolidation or maintenance, absolutely I would drop it. So for the consolidation, some of you may For maintenance, basically that's after transplant or after induction therapy. Most of you will not need to be on steroids at all during that time. You're probably just on lenalidomide. Some of you who have quote unquote high risk disease might be put on the same drugs that you were on during induction, again during maintenance or consolidation. Even then, though, I would say that you can drop the steroids at that point in time and just do the 2 active drugs and forget about the steroids. And then finally, some real life tips that I would recommend with these 2 figures who are excited, maybe because they're revved up on steroids. Some practical tips to tell patients about, or I encourage you to kind of consider on your own. So one would be to maximize your quote unquote sleep hygiene on steroid days. Sleep hygiene is our term for basically trying to promote a good night's sleep. So, it sounds silly, but, try a weighted blanket, try avoiding cell phones or TV within an hour of bedtime, try avoiding eating right before bedtime, try a white noise machine. If you have an Alexa, set that to play white noise. Over-the-counter medications are generally fine for the vast majority of our patients, like Benadryl or diphenhydramine or melatonin. Some patients find that topical CBD helps, for example. You can talk to your doctors about that. And I would say whatever works, do it for sure. Get your eyes checked out or get new glasses. A lot of my patients tell me that their vision is kind of getting a little bit worse. They tell me that like 2 years later, and I'm like, well, have you seen your eye doctor or your optometrist? And they say, no, I haven't. And, again, the steroids will change your vision. Even if you're not going to get cataracts or glaucoma, just the sugar itself, sugar tends to attract water. And so people's lenses, by definition, do get a little bit cloudy no matter how old or young they are. So if you have glasses and you feel like your vision's not where it is, talk to your optometrist, and if they can adjust your power and that's easy to do, then do it. Take Dex with meals. I know I said to take it earlier in the morning if possible. So maybe you can take it with a snack in the morning. That might be ideal to avoid heartburn. Some patients do need antacids like Tums while they're on it, and that's totally fine. Make regular PCP appointments for bone health and diabetes screening. So again, independently of all of this, steroids or even MGUS, just anything, or just getting older can cause patients to become osteopenic. That's the word for having weaker bones. We do use zoledronic acid or Zometa or Xgeva or denosumab to strengthen bones in our patients, which should treat osteopenia, but it'd be helpful to know. Similarly, if you're at risk of diabetes, it might be worth talking to your doctor and getting an A1C checked for your diabetes or pre-diabetes, because that's also something that we can adjust. For the leg swelling, you can elevate your legs at night. You can wear compression stocking, things along those lines. A lot of our patients, especially those who have amyloid, we do often end up starting a diuretic. That's the word for a water pill like Lasix that basically helps to just make patients urinate more, and that sometimes helps with the leg swelling. And then exercise regularly. I mean, you'll hear this from everyone you talk to on this website, on Myeloma Crowd, and every doctor, everybody. Is super important for multiple myeloma in general, just in terms of promoting bone health, but specifically with the steroids and this long-term risk of, weakened core muscles. The more you exercise, the more in shape you are. It doesn't have to be crazy, but just walking around, staying active, the better you'll do in terms of treatment and the better you'll feel. And then my final piece of advice is to join a patient support group. I have no doubt that, by selection bias, those of you who are listening to this audience are very engaged with your myeloma or your loved one's myeloma, and probably are part of a support group like Myeloma Crowd, but also if you have one in your local community. I know here in Seattle, we have a patient support group, the Myeloma Fighters, for example. That's often helpful because you may find that just bouncing ideas off of someone who literally has been through this and has been on steroids and has some excellent tip or suggestion that I had no idea was an option, like acupuncture or a different CBD topical something or something along those lines might be helpful. And I feel like just talking to people, knowing what to expect and being engaged as part of that journey is super, super important. And I think that helps a lot with this. So in terms of my concluding thoughts with steroids, so Dex was once the hero, and now it's very much the villain. And so really, that's kind of a joke of these, these pharmaceutical ads that all of us see on TV. Ask your doctor if dropping the Dex or lowering the dose is right for you. For a lot of patients, that is entirely appropriate, reasonable to consider if you're having issues with it. And I think it's you know this better than I do, that a lot of times, we're running around in clinic thinking about, as physicians, thinking about the next step, a transplant or CAR T or maintenance or whatever, and we don't really, or if we think about side effects, we're thinking about the Revlimid side effects, and not the Dex side effects. So if you notice something, send us a message and talk to us. I promise you that we won't be upset about that. I promise you that there is no study in the world that has shown that dex 20 milligrams, for example, is any worse than dex 40. And in my heart, I do truly believe that dex 20, for example, is totally fine. So it's not, you don't have to be, a super athlete, like fighting your way through this. You don't have to be suffering for no end, because I think that if this side effect of DEX is causing you problems, and if DEX 20 versus 40 or 12 versus 20 or no DEX versus 12 could just help you live your life better, that's a very important consideration that your doctor should know about. With that in mind, I will end with one of my favorite quotes from a book called The Emperor of All Maladies about myeloma, how it's not curable yet, but I really hope that we'll get there. And I would be very happy to take questions. Thank you all for taking the time to listen in.
Awesome. Thank you so much, Dr. Banerjee. That was amazing. I love how actively, how engaging the presentation was. And I'm really excited to get this conversation started. One of the things that I wanted to talk about was this dosing of DEX. So as you were just mentioning, 20 milligrams is just as efficient. And we know that kind of this 40 milligram standard has come a while ago. And I say a while ago because even in these past 2 years, myeloma research has accelerated at an unprecedented pace. I would like to see, and I think I appreciate that you brought up DEX can be the hero and the villain because of its synergy with other multiple myeloma medications. I have a lot of thoughts, obviously, but what I'm trying to say is, do you see another clinical trial happening like soon where the standard of dosing turns to that 20 milligrams or 12 milligrams? I mean, let's talk just a little bit more about that.
It's an excellent question. So yeah, I would love for that to be the case. So the kind of extension of what you're asking is, well, ECOG did this awesome study of high dose DEX versus high dose DEX. Can we do 40 versus 20? It's obviously difficult to get funding for these kinds of studies to be practical, and pharmaceutical companies are not that interested in it. I think the biggest issue is, a lot of our studies that are practice changing are sponsored by industry, and we have to work very closely with industry, with pharmaceutical companies. They're the ones who actually make these drugs possible, and I'm not meaning any slight to them. And these trials have to pass muster with the FDA, which is also very particular. And so I think by default, what ends up happening is it is very, very slow for clinical trial protocols to change. The example that I would give in this regard is some of you, for example, maybe, and this is a talk for another day, about proteasome inhibitors like Velcade or bortezomib. I tell all my patients, and I insist to every pharmacist I meet, that all my patients be on Velcade once a week and not twice a week. And so, a lot of our studies are still, they give Velcade day 1, day 4, day 8, day 11, meaning they give it twice a week as part of their, for the first 2 weeks as part of their cycles. There's no evidence in the world that twice weekly Velcade is any better than once weekly Velcade. Several studies, very large studies, have looked at patients who start with once weekly Velcade because the doctors like me, who kind of prefer once weekly Velcade for patient convenience reasons, and found no difference in outcomes of any sort whatsoever. But yet, literally even today, we had our SWOG, another big cooperative meeting last week, and even then I was like, hey, nudging the people who are presenting a trial, being, hey, do you mind making the Velcade once a week and not twice a week? Just because, again, it's really annoying to have to come to clinic enough once a week, twice a week, even more annoying. So we're working on it, but I think it's just frustrating that I think the clinical trials are not going to change anytime soon to allow that. I think what would practically happen is just provider awareness, that the docs are aware, the patients are aware, and that's enough for them to say, look, I don't need to worry about the DEX 40. Let me drop it down to 20 and just roll with it.
Yeah,
is there a way?
Sorry, go ahead.
Go ahead.
It's real world data, right? It's their own patients being able to advocate, hey, we don't need this 40 milligram. It could be just as effective with 20, and having almost the empowered patients bring about that movement.
That's exactly right. And the way that I would look at it is with induction therapy, the goal is to get to as deep of a remission as we're going to get to, and then we move on. As all of you know in the audience, induction therapy, which is where the bulk of steroids are used in the newly diagnosed setting, is not going to cure myeloma. Unfortunately, I wish that it were. And so, if someone, especially if someone's on track and like, they're on 4 drugs and you can tell that they're already, the myeloma numbers are coming down beautifully, especially for those patients, I would feel totally fine with dropping the steroids because whatever synergy the steroids offer might be overkill if it's having side effects, and 20 milligrams would be totally fine for those patients, if not everybody. But I agree that advocacy piece I think is super important. I will say that I think in amyloid patients, so patients with amyloidosis, they're often much more symptomatic from steroids. Some of those protocols have kind of dropped the steroids more consistently, or I've even heard on, I can make a plug for Med Twitter. Some of you in the audience may be on Twitter. I'm on Twitter. It sounds silly and political, but you often hear a lot of patient advocates and physicians talking about things. I've seen a lot of my colleagues, like myself, for patients with amyloidosis. As soon as we see their light chains going in the right direction, we immediately stop the steroids. Not just lower, stop, period. I don't think I'm quite there yet for most of my patients with active myeloma, but we might get there someday just by evolution of change, but it won't be soon enough.
Yeah, that there was a patient that was asking about clarification when it came to your comments on amyloidosis. So thank you for bringing that up again. I think that makes it clear. And how interesting, because that's not something that I've heard before, even in our amyloidosis chapter. So thank you for sharing that insight. Another question, what's your personal philosophy in including dexamethasone in maintenance therapy?
A good question. So my style is definitely not worth it. So for most patients, so maintenance comes in 2 flavors. So typical maintenance for most patients who don't have these quote unquote high risk features on cytogenetics on their bone marrow biopsy. Again, high risk doesn't mean high risk of death. It just means higher risk of the myeloma coming back sooner after XYZ line of therapy, including transplant. For standard risk patients, I recommend lenalidomide by itself, so Revlimid by itself, or another drug if that's not tolerated, or Velcade if they can't be on Revlimid for kidney issues, for example. The steroids I do not recommend here. For higher risk patients, there is a standard where we either give a drug like Velcade instead of the Revlimid, or sometimes combine them both. In that setting, I do lower the doses of all of them because we're playing kind of the long game here. So for example, let's say someone who does have high risk, quote unquote, myeloma, and I say, I'm going to put you on VRD after transplant or after your induction therapy, instead of Velcade being twice weekly or once weekly, I'd make it every other week. The Revlimid, the lenalidomide, I would keep only at 10 milligrams, not at 15 or 25, and the Dex I would absolutely drop. The biggest reason for that in my mind is this cataract study or wherever that was here. That's one of them, and I think the osteopenia, so the long-term issues of bone issues, is very difficult to quantify in myeloma because, as all of you know, patients have other reasons that they might have weak bones from the myeloma itself and everything else that's going on, and so difficult to say. I just don't think in maintenance that the again, because with induction, you're trying to slam the myeloma into as close to remission as possible. With maintenance, your goal is preserving a remission. You don't need to intensify things that much with a steroid, especially given their side effects. And the final thing I would tell patients, and this, I think the question asker asked is my personal philosophy, so this is my personal philosophy, is that if the myeloma is going to come back, it's going to come back. And it's not that a couple of extra little things here and there is not going to change that. I generally bring that philosophy up with regards to, for example, patients are asking, oh, like, can I take a month holiday from my therapy because I'm going on vacation or something, or if I'm on daratumumab, can I, stop the dara for the holidays coming up? And I say, yeah, that's probably fine, or go down on the dose, because in the maintenance setting, again, I think the drugs are going to work for as long as they're going to work. And when the myeloma becomes resistant to those, it's not going to be the steroids or that one extra dose of daratumumab that made a difference. Then we just have to try something different at that point in time. So for all those reasons, especially for maintenance, I'm very hesitant to recommend anything beyond Revlimid by itself. Even, for example, DARA. So in the Griffin study, for example, patients were on DARA maintenance as well, and I do not recommend that to most patients because that's DARA. In that study, it was 2 years, but in some studies, DARA, people think about putting people on DARA forever. And DARA absolutely does lower your immune system in terms of responses to vaccines and has side effects. Dexamethasone absolutely, as we talked about, causes blurry vision. Bone health might actually impair immunity in the long term. We don't really know. And so all reasons in my mind, I feel very strongly about avoiding Dex in the maintenance setting.
Interesting. Thank you very much for your thoughts there. I think this highlights the importance, the incredible importance of finding a multiple myeloma specialist that works with you to understand your personal situation, that aligns with your personal philosophies. Because of the 400 billion medications, that was an exaggeration, that are in multiple myeloma, transplant versus not transplant. There's so many differing opinions, all most valid opinions, but I just love your authenticity and your ability to share your personal philosophies. And I just want to emphasize to our audience today, if these philosophies align with yours, it's worth finding a physician that shares your philosophies. You never want to be uncomfortable with what's going on in your myeloma treatment. So just wanted to say that.
I totally agree.
Thank
Go
you.
ahead.
Lots of great questions coming in from the audience. So I'm excited to get started with some of them. Susan's wondering about the timing of Dex. When you take Dex, let's say with bortezomib or pomalidomide, do they have to be taken within 1 hour of each other or 24 hours?
It's an excellent question. Yeah, so that synergy I talked to is probably a long-term effect and not a short-term effect. So it's not critical that they be hour-to-hour time like that. That synergy of them working together is more in the long term. They do tend to help together, but it's fine. I would encourage, again, taking steroids as early in the morning as possible. And as soon as your clinic allows you to take steroids at home and not an infusion, I would recommend that, again, because even for the most early of risers, our clinics don't open until like 7:30 or 8. And so again, you're by the time you get there and get everything ready and take the steroids in clinic, it's already like 9. And so I think earlier in the morning, the better. In terms of the only exception to that rule would be for the first couple of doses of any monoclonal antibody when you're using Dex as a pre-med from an allergic or infusion reaction perspective, like I talked about, which is like a mouse antibody being infused into you. There, most studies and most centers will require that the Dex be taken within 60 minutes of the actual infusion. But honestly, each dose of Dex lasts about 4 to 6 hours in your system. So generally speaking, anywhere in that window is totally fine.
Interesting. Thank you. With what kind of patients would you recommend weekly Dex? We talked about weekly Dex versus
just twice a week Dex, for example.
Yeah.
It's a good question. So it really depends on the patient. It's funny because if you talk to myeloma doctors about it, we are really bad about assuming we know what patients would prefer. I've had plenty of patients. I've had like in my group, I've had like one doc be like, "Oh yeah, like I always tell my patients to take 20 and 20. I would never ask them to take 40 milligrams once a week. That's insane." And my style is, my guess is that more patients might prefer the reverse because it's just like they're like, "All right, Wednesdays are my steroid. I this is a day that this day sucks. I know that I have to get my steroids, go into clinic, get my infusions, and the other days I'm free of steroids." So I really don't know. There is no right answer. I'd have no reason to believe that taking Dex 40 milligrams every Wednesday, as opposed to taking Dex 20 milligrams every Wednesday and Thursday, for example, are any different efficacy-wise. I think it's just really up to the patient. And most pharmacists would completely agree with that. For patients who are having issues with insomnia, for example, as their cardinal complaint, I think that maybe splitting the Dex into 2 days might be more practical because it's very dose dependent. The higher dose of steroids, the more revved up people get. Conversely, if you're noticing that you're having, a lot of like letdown symptoms, for example, that also, I guess, then every other day might be helpful. Taking 2 days in a row might be helpful. But for patients who would be an example, once weekly might be better. For patients who are maybe like forgetful and it's like difficult to remember to do those kinds of things, or for patients where they feel like the Dex is helping with their bone pain or just helping with their energy level, then once a week is totally fine.
Do you ever have patients that take it once a month? There's a question about that.
I would say that if you're going to that level, it's probably not synergizing with anything. And my recommendation would just be to stop it at that point in time. There's certainly no harm in doing it. I don't think it's dangerous, but I don't think that it's adding anything at that level if it's being taken any less than once a week, because the total exposure to your body is kind of so fluctuant that it's not probably adding much benefit. So at that point, I probably would say to just stop it, because again, kind of my personal philosophy is that you're going to get as deep of a remission as you're going to get. And then with the myeloma is going to come back, it's destined to come back, just bad luck, unfortunately. And at that point, we would do something different entirely that would involve more drugs more commonly.
Yeah. Some people experience intense emotional reactions to dexamethasone, extreme anger, extreme depression. Do you have any patients that have experienced this? How do you work with them?
Agreed. It's really, really frustrating when that happens for both the patient and their caregiver. It's almost sometimes worse when the patient recognizes and they're just like, I can't help but be so angry and so emotional. So two things that I would recommend. So one is the easiest solution is, again, that would be a reason where I would say to just drop the dex entirely. Steroids do have a very, very low risk, but a theoretical risk of psychosis, for example, or mania. I don't expect that to happen to the vast majority of my patients. But if you're having that level of intense reactions, I would say probably there's some dose dependence too. So you probably can lower the dose or just say, you know what, stop the dex entirely. Try methylprednisolone, solimedrol, or just stop and just call it a day because the other drugs will do the heavy lifting. The other possibility would be, I think a lot of centers, unfortunately with COVID, everything's gotten very difficult and our behavioral therapists are extremely kind of overworked, understaffed, but sometimes, psychotherapy or CBT, cognitive behavioral therapy has been shown to help. I was telling Audrey earlier, some of my personal research involves the idea of life coaching. So I have a life coaching study open. Myeloma crowd, HealthTree actually has a coaching curriculum, and that might be helpful to just talk with someone who can who's been there where you are, kind of walk you through things. Oftentimes patients come and discuss kind of alternative strategies. So that might be complementary medicine, like herbal remedies or acupuncture. Acupuncture used to be very difficult with COVID, but it's gotten easier now, just for a variety of reasons. And I think patients with myeloma are immunocompromised, but not that much so. So if someone's willing to try acupuncture to help with their emotions, with the neuropathy pain that they're having, with any number of symptoms, I don't understand how acupuncture works, but I know that it works for a lot of patients. So I do recommend that, and people might find that to be what they need, or meditation or integrative medicine, something along those lines. And I think it's all worth pursuing. And that might be something where, the number of hours of all of my medical school and training I spent learning about acupuncture was 10 minutes, literally over the last, decade and a half of training. So it's not something that most doctors will be able to really answer, but I would say definitely turn to your support network, turn to Myeloma Crowd, try things that might work for you. And you may find that the solution to that, beyond lowering the dex dose, is trying something more integrative that might actually be helpful.
Yeah, thank you. Beth's asking an excellent question. Can you discuss why we're not considered refractory to dexamethasone even when we relapse on it?
An excellent question. It's funny you asked that. It's a very prescient question. So the short answer is that dex will always work. By definition, steroids kill lymphocytes. They kill cells of this lineage, and plasma cells are kind of terminal lymphocytes. And so, if you were to give someone, even if they were on their 18th line of therapy, if you were to give enough steroids, it would work. The issue is that it wouldn't work durably. Steroids don't work by themselves, and they don't cause deep responses, but they just will kill off some percent of plasma cells no matter what. So, for example, one of the critiques of some of the studies of selinexor, for example. So in the Storm, or was it Boston? I think it was Storm, where selinexor was studied with dexamethasone as just kind of a single arm study. And some people, including myself, were kind of like, well, some of the responses you saw might have just from the steroids themselves. You can't really prove that selinexor is adding to dex without doing a randomized study or comparing it to something. So basically, steroids, to the end of the hero question that I'd asked earlier, that I brought up earlier, steroids will always work. And so I don't think that anyone is truly steroid refractory in the same way, because it will always kill off the myeloma cells, versus with daratumumab, which is a targeted drug, the myeloma cells can actually stop expressing CD38 and permanently become refractory to it. Same for lenalidomide. They can engineer the intracellular mechanisms of how they work that block how lenalidomide works. Steroids work in so many different ways at once that I think it's impossible for any myeloma cell individually to become resistant to them permanently. So we don't kind of avoid that word, but I agree with you. It's kind of a weird principle.
Yeah, interesting. There's several other questions. Do you have just a couple more minutes if we go a
of
little
course.
bit
I can stay for another 5-10 minutes for sure.
Okay, perfect. So this last night during our Florida community session, we had an integrative doctor come speak to us, and she mentioned that sometimes she works with oncologists with patients who are not doing well with dexamethasone, and she actually can use curcumin to be able to synergize, like as almost a steroid replacement to synergize. Have you heard of these kind of research studies, and what are your personal opinions on them?
That's an excellent question, and also something like I got 10 minutes of lecture in all of medical school about acupuncture, 0 minutes about anything that's kind of herbal or integrative or anything. And so I can't speak to it with expertise. What I would say is that for turmeric in particular, or turmeric, however you want to pronounce it, for curcumin, which is curcumin is the active ingredient there are definitely preclinical studies that do show that it does work against cancers of the lymphoma of lymphocyte lineage that includes CLL, which is lymphoma, as well as myeloma. In my mind, the devil's in the details and the dosing. All these studies, for example, that show that red wine promotes survival. I've heard someone joke that you would have to be taking gallons of red wine a day for that to actually match what was done in the studies. I don't know enough about how curcumin was studied in these particular studies and if it's been studied in humans in that regard. And so we're kind of in an evidence-free zone. What I would say, what I tell patients practically when it comes to herbal, remedies or supplements or anything over the counter is that I am fine with trying it because I agree that some of them may help in ways that we don't fully understand, as long as it doesn't cause a particular side effect that I'm already worried about. So in the case of myeloma, any supplement, be that curcumin, or people have asked me about green tea or elderberries or anything like that, I can put it in the chat, or I can remind the audience, or if you Google it, Memorial Sloan Kettering Cancer Center has an herbal medicine database. I forgot the name of it, but it's MSK. If you Google like MSKCC herbal medicine, there's actually a tool. Their integrative medicine department has come together with this huge list of like all the supplements they've ever heard of and every piece of evidence that's ever been compiled with them and put it together. And so my litmus test is as long as whatever patients are on does not cause or raise the risk of blood clots significantly while they're on lenalidomide, or neuropathy while they're on something like bortezomib, for example, totally fine with that. What I sometimes get into issues with is like some supplements have been shown to raise the risk of blood clots, like estrogen supplements, for example. Those I get cautious of if someone's already on Revlimid and already on aspirin as a blood thinner, and I say, everything apart from that, I'm fine. So curcumin, basically turmeric, I'd be fine with, as long as patients kind of tell me about it, so I can put it onto our drug list, and as long as they've looked at the database, and it's fine. And it very well may have effect very similar to dexamethasone, and if that works, all the power to them. The only final caveat I would say is that for some clinical trials, they are very, very, very particular. So if you happen to be in a clinical trial, before anything entering your mouth that is a medication of any sort, talk to the team about it to make sure that it wouldn't, prevent you from getting the study drug, for example.
Yeah, thank you. And I would just also add, she really emphasized it was a holistic doctor who had been through medical school, who had done her work, and she works with very like high quality supplements, and she works in partnership with oncologists. So this is not an invitation for anyone to drop their ducks and go to the store and buy some curcumin or turmeric. It's rather, if that is interesting to you, maybe that's something that you look into and speak to your treating physicians about.
Agreed. I'll quickly add that many centers have integrative medicine centers built into them, or integrative oncology. My biggest frustration is insurance companies often don't pay for the consultation, which is supremely annoying. But ask your doc. You may well have, a side referral we can place that hopefully insurance would cover, that offers, talks about curcumin, talks about lifestyle, talks about yoga, talks about acupuncture, and much more, which I think is super important.
Definitely. Thank you. Lori's wondering if it's worth it to get cataract surgery because the cataracts are worsening now that she started Dex while she remains on Dex. So is it worth it?
It's an excellent question. It depends on how worrisome they are to your vision, is what I would say, because I think the trajectory of steroids and how much they worsen cataracts on like a month-to-month basis is a little bit unclear. I do think that I would much rather patients preserve their vision, because that obviously is supremely important to patients. And if you notice your vision is objectively worsening by your own measure of what you're looking at, then I think it's quite reasonable to take care of it. I would just coordinate with your medical team. Cataract surgery is very, very, very safe, and so there's no issues of systemic issues, not have to be about blood clots or any of that, but just time it around your therapy so that you don't inadvertently have to have a delay or a complication and delay your myeloma therapy based around it. But I think it's entirely reasonable, especially if you're symptomatic from it.
Awesome. Thank you. I'm going to go briefly through a couple of questions. Susan's wondering, let's say she's taking 20 milligrams, talks to her doctor about interfering with their quality of life. Doc says it's okay to decrease to 12 milligrams, but without effectiveness data, why would she trade quality of life issues if it might mean lower of efficacy? I mean, honestly, I think this is where it comes to being like the personal philosophies. What feels better to you? Does it feel better to have a higher quality of life, or does it feel better to you to know that you're doing all that you can in terms of efficacy? So any thoughts on that?
Agreed, and I would agree with that entirely. It's a very difficult decision. It often depends on the side effects. Having bad swollen legs that can get better with compression stockings and Lasix is very different from feeling jittery, not sleeping, feel like a monster, emotionally labile, etc. So it really depends on each individual case. What I would say is the benefit of myeloma is that we are never, ever, except for CAR-T, I guess, dependent on a single drug working all by itself. We're always tag teaming drugs together. And I would say that if someone's achieved a PR, a partial response or better with 4 drugs, and they ask me, for example, conversely, if someone had an issue with people with having neuropathy with DARA-RVD, the neuropathy I have from the Velcade, I wouldn't blink twice about stopping the Velcade, period, and just going to 3 drugs because we're already starting at 4. So 4 to 3 is still pretty good. And similarly, if someone's on 4 drugs and the steroids are causing problems, we go to 3 drugs, probably is fine because each drug works in a different way. And for patients where the therapy is responding to the treatment, I think that would continue to be the case even without the DEX. So it's difficult. The other thing I will say is that, and I tell patients this, Velcade is dosed by people's height and weight. DARA is based by people's weight, the IV formulation of it. Steroids are not dosed by anything. Same with Revlimid. Those 2 medications, you give everyone 25 milligrams of Revlimid and 40 milligrams of Dex and just kind of see what happens. And that dose is absolutely not for everybody. So I think that it's much better to be on a dose that's manageable and will allow you to stay on therapy for the long haul and not cause complications or delay your therapy, God forbid, for example, if you're having, refractory leg swelling or issues that are preventing you from just showing up to therapy on time. That's the problem. And so I think lowering the dose to where it's manageable is appropriate.
Yeah, there's some other questions here. What about 30 milligrams? What about 8 milligrams? And maybe this is wrong for me to say and not medical. Obviously, I'm not a medical professional at all, but if they've found something that works for them within that 40 to whatever range, 0 range, is it worth it?
Totally fine. So if you're nervous about going from anything, yes. So Dex does come in 2 milligram, 1 milligram, and 0.5 milligram tabs. You would have to basically do the mental math and put for 30, you'd have to do 4 of the 7s and 1 of the 2s. And sometimes it gets annoying with pharmacy to prescribe them because you have to remember that you prescribe both the 4s and the 2s and get refills of them and so forth. So probably a multiple of 4 probably is the most practical, I would say. Is 28 milligrams of Dex fine? Totally fine. I suspect that 40 milligrams is a lot for a lot of patients. If 28 ends up being a sweet spot and the side effects are manageable, again, some of the side effects of steroids are probably dose dependent, meaning that the higher the dose, the more they happen. Some of them probably aren't. So for example, the blood sugar going up, probably no matter what, even Dex 4 milligrams probably is enough to make people's blood sugar goes up. So that is going to happen no matter what. But the jitteriness, if 28 milligrams works, all the power to you, and just again let your doctor know, talk to them about it just so that they can keep track of everything and not mess it up for future cycles. But that's very reasonable. Below 12, yeah, that's where I start to feel like it's so basically 1 milligram of Dex is equal to let's see, HPMD 570, 5 times stronger than prednisone. So 8 of Dex is about 40 of prednisone. Some of you who know prednisone, that's about the dose that we use for prednisone for allergic reactions or contrast allergies or whatever. When you start going below 12 milligrams into the 8, 4 range, you're starting to enter the quote unquote normal range of steroids, which probably are not enough to kill cells. They're just enough to suppress the immune system. So for example, 8 milligrams of
sorry for interrupting. The patient that was talking about 8 milligrams did it for bone pain because it was really affecting without the dexamethasone. It was about pain. So I think that's definitely a reason to stay.
Yes. So the only thing I would say is that if you're on Dex for more than once a week and more than twice a week, if you're on Dex every day, even 2 milligrams of Dex once a day, indefinitely, you absolutely need to be on Bactrim, on medications to prevent rare infections. And you absolutely need to consider, screening for osteoporosis and some of the other side effects of Dex. So this slide I brought up here about susceptibility to infections. For patients who are on daily steroids, they absolutely, that's like a, a life-threatening risk of getting a
Yeah,
weird infection. But if it works for pain, do that, and just, be wary of this particular side effect and be on the lookout for medication to prevent it.
definitely. Okay, let's hit two other questions. So the first one is, let's talk about other steroids briefly. We've talked about dexamethasone the majority of this time. Are there any other steroids for multiple myeloma that are less bad for bone health than dexamethasone? And what other steroids are available in myeloma treatment?
Absolutely. So in terms of systemic steroids, I'm sorry, that can be given either orally or IV. These are the ones: hydrocortisone, prednisone, methylprednisolone, and dexamethasone. For patients who are taking pre-meds of dex, probably for allergic reactions, for infusions, for monoclonal antibodies, methylprednisolone, we've had a couple patients where we do that, and some protocols allow for them. That's fine. Prednisone, there are some studies. So, 15 years ago, and my first slide from like 40 years ago, we used prednisone by default here for lymphoma, for example, which is a similar type of blood cancer. We use prednisone all the time as part of our CHOP therapy. So why pred and not dex in lymphoma? Why dex and not pred in myeloma? It's entirely just a tincture of time. You're welcome to try it, and we can do the math. There's a conversion that we can estimate between these. And it's worth a trial. If you're worried about that, it's worth a trial. I do think that the class effects of these are pretty typical, and the odds are high that if you're having a side effect with one of these, you'll have it with the other ones as well. And then for bone pain in particular, I learned in medical school, I don't know if people have studied this in a systematic way, that dexamethasone is just a little bit better for bone pain just because it has some more anti-inflammatory effects per dose than prednisone does. So I would say probably dex for bone pain in particular over prednisone. But again, if you're having side effects, you need to be on a medication. It's worth a discussion with your doctor. And the best way to find out is to try it and see what happens.
Do you personally use the methylprednisolone with any of your patients?
A couple of patients, if they have issues with the dex, mainly kind of like the psychosis or like just a really intense emotional reactions to dex, and if they need it as a pre-med, methylprednisolone, so sodium medrol, we can be given IV in clinic, for example. It's a little complicated because the dosing gets messed up, and dex, just to be clear, like 40 milligrams of dex is like 200 milligrams of prednisone. If any of you have ever been on, a prednisone dose pack or something, or a medrol pack, it's like 15 times stronger than what you would be getting on a medrol dose pack for poison ivy, for example. So it's difficult to kind of convert. A lot of pharmacies don't have enough of those other pills on stock, or don't have the IV bag that big on stock. So dex is just practical because we have it. But I think talk to your doctor, and they can probably try experimenting with it if needed.
Yeah, thank you.
Mm-hmm.
Last question here. John's wondering, he's taking Pomalyst 3 out of the 4 weeks. Do you ever recommend that they take Dex on the off week of their month?
Excellent question. Yeah, because these protocols were all just kind of made up, 15 years ago, and roll with them. So just so as many of you know, so with Revlimid, we often recommend taking it 14 out of 21 days or 21 out of 28 days. Same for Pomalyst. We say, take it for 3 weeks on, 1 week off, for example. Generally speaking, for the off week, I recommend just keeping it as the off week, just to really give people a chance to reset, and just like make their appointments during that time, live their life during that time. I think Dex by itself is a pretty lousy drug, just a single dose here and there. I think it works best when added to other drugs in general. And so I think for off weeks, I generally say make it a complete off week. The antimicrobials, like the acyclovir, you still need to be on and stuff like that because of the long-term infectious risks. But on the off weeks, I would say keep them off weeks. It's probably just easier that way. But are there any exceptions to that rule? Not really. I think I would say that if you're allowed an off week, it actually was designed to kind of help mitigate some of the toxicities of that particular regimen. So make the most of that off week. If there's no benefit to trying to sneak in some extra pills, because they're not going to add that much bang for their buck.
Awesome. Thank you so much. One last thing. I just see a lot of comments about, you're talking about taking it in the morning. Sometimes patients feel a lot of success taking it right before they go to bed. And I think, it comes back to what works best for you. For some patients, it's going to be taking it at midnight right before they go to bed, which kudos to you if you go to bed at midnight. And then some people it's at 5 a.m. when they wake up in the morning. So I think Anyway,
It's
I've really appreciated this discussion. I've appreciated
excellent
seeing the
point.
different views of different myeloma patients and how they're interpreting this and incorporating it into their life. I apologize that we didn't get to all of the questions, but thank you, Dr. Banerjee, for being here with us today. Do you have any closing statements before we finish today?
No, I just want to say thank you all for having me. And I think all of you are obviously self-selecting population. You're very engaged with your myeloma care. You're here on this call. But I would say definitely, yeah, no doctor will ever be upset if you ask a question about side effects, or I read about this on Myeloma Chronicles, a vetted website, and there's a lot of things that doctors don't have time to cover. It's not that we don't know, we just forget to bring it up or don't have time to bring it up. So be proactive,
Exactly.
bring it up. And I think that's an important principle.
Yeah, it's almost, I don't know if I'm supposed to say this, but it seems a red flag to me if you try to bring up the conversation about lowering dex and they just don't even want to talk to you about it. I'm not saying it's a red flag if they don't necessarily want to lower it for specific reasons that they've proven to you. Sorry, that's my
yeah,
son.
no, it's about, and what I would say then, and if you're worried that your doctor's just too busy, I would say save it for a MyChart or I shouldn't use brand names, like a message in between. I would actually much rather a patient tell me about a side effect by MyChart message, and then I can deal with it in between, rather than when they see me, I only have 30 minutes scheduled for them, but I need to talk about this and about transplant and about MRD and blah, blah, blah. So if you're ever in doubt and you feel bad that the visits are so busy, ask in between. Definitely, we don't mind, and most of us have centers and nurses who can help us triage questions and figure out a plan in between.
Great advice.
Great.
Thank you so much.
Of course.
All right.
Thank you all
Bye,
again for
bye,
your
Dr.
time and help. Have
Banerjee.
a
Thank
wonderful
you.
evening.
We're going to finish up with just a couple of outro announcements. Our next meeting will occur in January. We're going to take a couple of months off, and we're going to be discussing myeloma therapy, what's available for induction therapy. Don't forget to take that exit survey so that we can get your feedback about how you think today went. Join us for other events that you might be interested in. Looks like I forgot to update this slide, so I apologize for that. But tomorrow is going to be at 2 p.m. Eastern, the Black Myeloma Health Chapter, why Black myeloma patients and their families should care about the PROMISE study. Other upcoming events is found at the link on that slide and will be included in our follow-up email. A special thank you to our sponsors, BMS, GSK, Genentech, AbbVie, and Amgen. And thank you so much for taking the time out of your evening to be here with us. We hope that you have a great rest of your day. Thank you, everyone. Bye-bye.